Welcome to Connecticut eHealth Podcast, educating, conversing, and connecting for better health. The Connecticut eHealth Podcast is a space where we get together with local and national experts, key stakeholders, and other individuals in the space of eHealth to discuss health information in Connecticut and around the country. This podcast is brought to you from the EConSults Interoperability, Innovation, and Learning Lab, where our mission is to promote the optimal adoption and use of eHealth by providing education and engaging in conversation with leaders to create connections for better health. So let's sit back and get connected. Hello, my name is Tom Agresta. I'm a family physician and a clinical informaticist at the University of Connecticut, and I'll be your host for this episode of the Connecticut eHealth Podcast. Today's guest is Dr. Todd Staub, the Senior Vice President for Physician Relations at Optum Care. His educational background includes a BA in psychology from UCLA, an MD from Albert Einstein College of Medicine, and a residency at New York Presbyterian Hospital in internal medicine. Dr. Staub has previously served as the founding member and chairman of the board of directors at ProHealth Physicians, which is how I came to meet him. ProHealth is the largest primary care clinical group in Connecticut. He's also a founding member of the Connecticut Center for Primary Care, which focused on research and innovation to improve the effective provision of primary care. Thank you for joining us, Todd. It's a pleasure to have you on the show.
Tom, great to be here. Thanks for having me.
So, Todd, give us a little bit of background on yourself and what your prior and current roles have kind of taught you about current practice of clinical medicine today.
Yeah, so first and foremost, I'm a primary care physician, a general internist, and I saw patients for 32 years, went to the hospital, was a school doc, nursing home physician. So, did that and helped to found ProHealth Physicians. That was about 25 years ago. That's one of 81 little practices, much like the one I started back in the day, came together to create a group practice. That was a lot of hard work, getting docs to be on the same page, each of which had their own little mom and pop shops. And you were on the board for that, Tom, so you know full well that it was quite a journey. And then about a little bit more than 5 years ago, ProHealth Physicians became part of Optum Care, the delivery arm of Optum. And since that time, I've been helping to grow Optum Care across the United States.
And in those roles in your background, what did you observe about clinical practice that you wanted to kind of bring together this, small practices, and what kind of drove you to do that?
Yeah, I think back in the day when we formed ProHealth Physicians, primary care in Connecticut was very fragmented. I'd say the great bulk of primary care that was delivered was in practices of 1 to 4 doctors. That's all changed since that time. Our goal was to really try to create our own future. This is during the mid-90s when there was a lot of change going on across the country. So our thought was, well, can we come together and create something better? Something that preserves the traditional values of primary care, but brings it into a new age of practice.
Excellent. And I know that throughout that process, the effective use of technology was one of the things that you championed and helped to move forward. Tell me a little bit about that process in ProHealth.
Yeah, getting everyone on the same page in terms of technology, data. One of the early things we did is we created our own lab, and we drew blood on our patients and got lab values. And that was our first foray into kind of a uniform data set. And that allowed us to get into pay for performance contracts, especially around diabetes, where we could document their hemoglobin A1Cs when they were done, LDLs, et cetera. And then some years later after that, around 2008 or so, and I think you were on board at that point, we went from paper to EHR, which was a very, very tough process, but one that we had to really tackle and master. And we did that. We got 75 sites up onto all scripts, all the modules. We got every site to level 3 medical home, and we got all sites to meaningful use. And we did that in a 3-year period of time. And that's a boatload of work. I would say that was a culture-defining 3-year period of time where we really proved that, when we came together, we could accomplish great things and really move the needle on value-based care.
Yeah, it was an amazing time frame, and I did get a window in on that experience, and I can tell you that ProHealth was a group that was really focused on trying to do this in a way that preserved the values that the clinicians and the patients both kind of really were aiming at. That's basically the best possible outcome in patient care at the lowest, disruption for the clinician, which was a challenge at that time.
Yeah, it was a challenge, but you can't change care without changing yourselves. And so it was a real cultural journey for us as physicians and the offices to come together and learn to be on a team, which is really, I think, the theme of healthcare over the last 20 to 30 years is it's not an individual sport. This is a team sport. And, how do we come together in a cultural sense to learn, what's my position, what are the plays, can we practice them together, how do we execute on the field, et cetera. So it's quite a journey and something that we're now doing at the national level in Optum Care. So just, a chance to talk about that. I saw what we did in Connecticut. Out of 81 little practices, we grew to become 260 physicians, 130 advanced practice clinicians taking care of about 10% of the state, about 350,000, 400,000 patients. And then when we became part of Optum, we were group number 9. And I saw an opportunity to create a whole new delivery system across the US. And instead of doing this with small practices in a state, we were doing this with groups of 3, 4, 5, 600 doctors, per group. And now in Optum, there's 40 large groups across the United States, and we're trying to basically do what we did in the state of Connecticut: is organize physicians into more meaningful organizations to have the wherewithal to change healthcare in a value-based way.
Yeah, it's an amazing transition you're describing there, and obviously it's a description of the journey of healthcare in the US becoming larger and larger groups collaborating, hopefully collaborating, I would say, in effective ways. And as you've moved into this role for Optum, what are you noting about how eHealth has a role to play in supporting and detracting from those processes?
I think let's go to the detracting, first. I think, all of our experience going into EHR is it was not the best experience in some ways. There were some immediate advantages, but there was a lot of clicks, a lot of screens to look at, and it kind of slowed down care quite a bit. So, the workflows were not the right workflows. We took the old ones and we tried to digitalize them, and I think we've got some work to do there. But I think the real promise of digital care is, I think about a third, at least a third of the care we deliver could be done in a digital format, one way or the other. Either through digital interactions between providers, clinicians, and patients, or self-care by patients. Our patients are smart. They understand. They're willing to participate in their care. So how do we make doing the next best thing easier for them to do without having a choke point of going to sit in a waiting room somewhere? So I think digital health is it's part of the new world that we're operating in, and we need to embrace it.
Yeah, those are excellent observations. And as probably most of our listeners know, or perhaps they don't, but we're kind of heading into a primary care shortage from the terms of the number of providers available, especially as we have an aging population and we have a growing population and an aging physician and clinician workforce. So it's going to be critical that we utilize new tools to kind of engage patients. And I'll bet you have some viewpoint from your role in Optum about how this could play out and how it could be something that we take advantage of in an effective way.
I think in Optum, we're very mindful of this, and I think all of us need to be mindful to the point that you're raising, that there's a shortage of manpower in healthcare in general. I mean, nurses, advanced practice clinicians, physicians, even specialists. there can be a shortage of those folks, but particularly in primary care. So whatever model of care we designed, if we're not taking into account workforce issues, we're going to fall short. So I think that digital allows us to utilize the intellectual capital of that workforce in a much smarter way that helps us to manage larger populations. And we've got to be very creative in how we think about matching up the talent that we have in our workforce with the job that needs to be done. It's really a supply chain, issue. And I think digital is a key part of that.
Can you perhaps give us an example of how you think about that when you're talking with your clinician groups and you're strategizing for the future?
Sure, I'll take something that's been around for a while, but needs to be scaled. Let's look at eConsults, for example. So back in the day when I started out, we primary care, we did tend to manage maybe a bit more of things than maybe today. But if you needed to do a specialist referral, you had to call the other office or give the patient the contact information. They would have to make an appointment, get in their car, go sit in a waiting room, et cetera. And it was very cumbersome, to kind of make that trip and go see that specialist. At the same time, in those days, there were something called curbside consults because we rounded in the hospital. We could see our specialist colleagues and we could say, gee, I have a patient with X, Y, or Z. What do you think? Well, all that's gone by the wayside now. There's no in-person curbside consults that are happening because doctors, primary care stopped going to the hospital. So how do we facilitate the interaction between specialty and primary care in a way that makes it more efficient? So I think e-consults are a way to do that. They can be asynchronous in nature, so the specialist can kind of batch them up to the end of the day, and they can be quick. It's also a way to create best practices within a specialty. If I ask a specialist an interesting question, if you look at your queue of appointments out for the next, couple of months, because a lot of specialists are booked out, how many of those consults are just stupid? Why am I going in the room to go see this person? Why doesn't Dr. Staub just do blank? And so can we teach our primary cares, we want you to manage up to X level, and then now it's time to refer that patient. So I think an eConsult platform is one way we can use digital to streamline care a bit, make it a bit more efficient, be able to tell primary care providers, on the spot, gee, if you just do these things, maybe I don't even need to see this patient, or I could see them in 3 or 4 weeks. There's not a rush because you're already doing what I would do right now.
That's interesting. And eConsults, I think, are an absolutely critical tool that needs to get deployed more fully. And it's certainly something that has proven time and again when they've evaluated its effectiveness to be, not only reducing wait times and access issues, but also probably improving quality and outcomes as well. And it sounds like that's something that we could really kind of take and digitize and do a whole lot more effective job at. Can you talk?
Just one.
Go ahead.
Go ahead, Tom.
No, go ahead and fill it in.
Well, I'd say that another area I think where digital is really making an impact is just in how do we manage the sickest 2%, 4% of our population? How do we identify them? So using predictive analytics to say, here's your sickest 2% of your population right now. Here's where they are. Here's what they're doing. Here's where they're turning up in the ER, rehab units, hospitalized. And it allows us to really intervene in that very expensive kind of cadre of patients and help them get to a better place, stay home, be a bit healthier, kind of get them what they need just in time. And then using those predictive analytics to say, well, here's your next sickest 2%. So let's start providing them support. And then digital allows us to reach out to those people in a more cost-effective way. It helps to meet them where they are. So I think digital, when you look at population health, it's hard to imagine doing it without a digital kind of backup, without that data warehouse, predictive analytics, outreach tools, et cetera.
Yeah, so there's the predictive part of it, and then there's the, once you do the outreach, how are you going to be doing the remote patient monitoring? How are you going to be doing the interaction with them and their caretakers or family members in order to sort of, make decisions, on the spot about how to best care for them, or even ahead of time, how to best care for them. So what you're really describing is this transition to sort of value-based care. And could you describe for us your what you when you go out and talk to people, what do you talk to them about as meaning value-based care?
I love this question because value according to whom? And, I think that as physicians, we have our own ideas about what value based care is, and they're totally legitimate. It's about quality, and we know that there are certain quality standards that care needs to meet, and we need to put in the systems that help us meet that. There's cost considerations. Healthcare is so expensive. It's really hard for your average person, average family to kind of pay for healthcare. Healthcare has consumed almost every pay raise that workers have had for the last 30 years, and it's our accountability, our responsibility to help get that cost under control. So there's cost and quality concerns, that I think that we're all focused on. But what about the values of patients? What matters to an individual patient? What do they hope to get out of a procedure or an interaction with healthcare? And I think this is where primary care is so central because we've always spent time getting to know and build trust with our patients and understand them. So trying to make care fit individuals so that it meets their values and goals. And I don't think we have enough of that right now in healthcare where we measure, am I meeting your values and goals in delivering healthcare to you?
I love turning this, question about value into adding in the sort of ethos and the ethics and the morals of value, because as we know, value is in the eye of the beholder. It's a bit like beauty, right?
True. And someone who's paying for healthcare, they've got a set of legitimate set of values, and then for providers, hospitals, physicians and other clinicians, we have resources that we have to be good stewards of. But I do think that really getting down to the nitty gritty, what matters to people, we know that more care is not necessarily better care. And I think we tend to sometimes deliver excessive care to patients that they don't necessarily want because it does take more time to understand people and to make sure that we're designing care in a way that meets their needs and goals.
So are you seeing this sort of definition of value playing out in organizations in your role through Optum? Are you seeing sort of this holistic definition of value? And if so, what can we do to achieve those things in Connecticut?
I think that quality and cost, I mean, those are very important, and we need to drive at those in terms of value. And it can't be overstated because healthcare is so expensive that it just becomes an access issue, for people. They can't afford to get X, Y, or Z medication. The copays for, intervention are too much for them. So we do need to focus on that. But I do think that we need to change the way we look at asking the question, are we doing a good job? The CAPS questions that we ask, really to paraphrase Elizabeth Teisberg, who's down at Dell Medical School, how great are we? Aren't we wonderful? Do you really like us? Versus we're really meeting your goals. We understand your goals. We are meeting your goals. We're really understanding you, building trust, and getting you where you need to go. And we don't ask enough of those questions. So I think we need to design new tools to surface that. This is something that primary care has always done. I've been a small town doc. I live in Litchfield, Connecticut, and I've taken care of people here for a long time. And you get to know your patients, and it's something that you keep in your head. But now it's when we're delivering team-based care, I think we need to go an extra distance to understand what matters to this person and how are we going to deliver care that is consistent with their own values and goals.
Yeah, that's a great set of comments. Are you seeing any best practices throughout the country in doing that?
I mentioned Elizabeth Teisberg down at Dell Medical School because she's made a career out of measuring this. So I think I haven't seen a lot of good examples of this, frankly, Tom. I think this is something we all need to work on to make this part of our groups, our practices in terms of delivering care.
Well, that's interesting. So maybe we can take a brief pause to, hear from our sponsor, and then when we come back, we can kind of pick up on this thread and think about maybe how our health information exchange activities could help us with that. We want to take this opportunity to thank Connie, Connecticut's official health information exchange. Connie was established in 2019 to oversee and provide services to support the exchange of health data in the state of Connecticut. Connie is an independent and not-for-profit organization. To learn more about Connie, please visit conniect.org or go to the show notes from today's episode. So Todd, as we come back into our conversation, let's reflect back on what you said about value and ask what is potentially happening nationally around information exchange, and also what could be happening with the use of Connecticut's newly minted health information exchange, Connie, that would lead us towards that value.
Yeah, so Tom, I'm so grateful to see that we're finally making progress on the HIE front in Connecticut, and it's been long overdue and great to see this progress. It's hard to imagine delivering value-based care without that kind of infrastructure. We need to have a 360-degree view of what's happening with our patients. There's so many healthcare silos that exist out in the healthcare ecosystem, and we need to kind of pierce those silos and see what's happening inside of them. How else can we deliver value-based care to the people we serve without that information?
Yeah, it absolutely. The healthcare silos for data is one thing, and it also kind of reduces our capacity to do some of those analytics you were talking about, the insights that might kind of look across systems. Can you give some examples, perhaps from your own practice experience or from your work at ProHealth, where information exchange might have really made a difference or could make a difference kind of going forward?
Yeah, I think one of the first things that comes to mind when you ask that question is around transitions of care. So going from home to the ER to the hospital to post-acute, post-acute back into community. Every time there's a transition in care, there's a tough handoff that's going on now. And 30 years ago, 40 years ago, there was actually a doctor involved in that journey. Where we saw our patients in the hospital, we saw them in the nursing home, the rehab unit, and we saw them back in the community. And I could say that was pretty hard work, even just doing it yourself, where the handoff was to yourself. Now there are discrete teams in all of these places. The kind of willingness of clinicians to move from one venue to another is limited now. It's just reality. So how do we bridge those divides in transitions of care with data, with information? And I think that's where HIE is so important, because the number of errors that can occur, the number of drop-offs of key information that needs to be passed on, it just can lead to so many missteps and failure to meet quality criteria. So I think that this is where HIE is critical around these transitions of care.
Yeah, absolutely. And as we get better at actually passing discrete pieces of information and also passing stories at the same time, I think they're very different things in those transitions. So the discrete information might be medications, right? But the stories might be what the values proposition is, those things you kind of mentioned about what a patient prefers and how they prefer it, right?
Yes. And just a commentary is that, right now, a hospital discharge, if you look at it, it could be 50 pages of information. So how do we prioritize the information in these transitions of care in a way so that the provider, the clinician, can see what do I really need to know to take care of this person? I don't have 3 hours to kind of read through everything here. I need to know in the next 20 minutes with this patient in front of me, I have to make decisions. What do I need to do next? And so how do we begin to prioritize that information? There's and I'm going to forget the name of the person. I think it might be Herbert Simon. I'm not sure if I have that right, but a wealth of information creates a poverty of attention. So there's almost too much data that comes through sometimes, and it's hard for individual clinicians to sift through literally 50 pages of discharge information to find out, what do I really need to know? Is there a 1 or 2 pager in here that condenses all of that? So I think that's a challenge as we go forward, is how do we take this data exchange and make it more informational, actionable type of data?
Yeah, those are great observations. And I certainly have been on the receiving end as a clinician of the 50-page discharge summary and had to try and figure out where was the, actual final assessment and set of information. So if we're talking about information exchange and an actual HIE, what would your recommendation be about helping that HIE pull together data in a way that really facilitates that?
I think that's one goal is to set the pipes up and just get data moving between different places. I think the next challenge would be, could we use artificial intelligence and machine learning to help us sift through that data to find out what's the critical mass of that data that clinicians need to see. We have to make things a little easier, because buried in that 50-page report is a CAT scan with a lung nodule that if it wasn't on the first or last page of this thing or the first couple of pages, but you still need to see that. So can we use digital tools to help us do some data visualization, so I can see very quickly, what do I need to know to take care of this person? Because everyone's busy and there's not enough time in the day, to bombard people with data that they don't really need to get through.
Are you seeing anything at the national level that kind of gives you hope that we're moving in that direction?
Yes, I think we're using natural language processing. So we're extracting data from kind of just speech and notes that are unstructured, and using machine learning and artificial intelligence to shape that into something more discrete and condensed. So I think there is quite a bit that's going on, and I think there's going to be a lot of work to do over the next decade. You can't fly a plane with an Excel spreadsheet. You need dials, you need things. I can see now what I need to do, and so very similar in healthcare. It's like flying a plane or driving a car. We need gauges and things that tell us kind of where we are, where are the critical levels, et cetera, and what do we need to do to maneuver to the next best thing for us to do. So it's quite cumbersome right now, I think, for clinicians, and that's where the frustration is. That's where burnout is coming from, is that we don't have the right tools for managing the complexity of care. Something we measured in ProHealth Physicians back in the day, and I'm sure it's changed. How many data points were we collecting in the course of a visit? It was well over 200 data points that we were trying to collect in the course of a visit. And I had a conversation with some leadership at Kaiser, and how many quality data points were they tracking? Over 700 kind of data tracks. So healthcare's gotten a lot more complex from when I started as a young physician, and where, I would see the cards that the old docs, would have, and they would write, physical normal, and they would have 20 years of information on a, 3x6 index card. Those days are gone. Medicine's a lot more complicated, and we need to give clinicians tools to help navigate through that sea of data more efficiently.
Yeah, and keep it accurate too, because old data that isn't changed is no longer accurate data, right? So
Right.
updating things like, physical findings, to reflect that a surgical intervention has occurred or that something has changed in terms of medications shouldn't be something clinicians need to spend their intellect on, right? It should be sort of happening for them.
Agreed. And I would say that med reconciliation, just that alone is what is what's actually going into the patient's stomach? What are they actually taking on a daily basis? It almost is it's an elusive goal to understand exactly what that is.
Well, I think that is one place where you'll be happy to know that our state's HIE, Connie, is actually trying to work on that. They're trying to put together what they call a BPMH, or best possible medication history, with I think the emphasis on possible, because as you and I both know, that is a changing reality. But they are working on deduplicating and kind of looking for emissions and presenting that in front of clinicians in their workflow. So that is one thing that I can share with you, and hopefully make folks' jobs just a little bit easier with HIE.
That's great.
So, Todd, you and I have been talking about HIEs and about data exchange and analytics for well over a decade now. Um, Tell me what you think some of the unique challenges Connecticut is facing, will face, in order to really stand up a highly functional HIE.
We tend to be culturally fragmented state. We have all these townships. It's just our history, how Connecticut evolved over the last, 300 plus years. And, that's kind of baked into us. So how do you begin to stitch together, all these different locations where care is being given? And we have a very kind of New England philosophy. That town over the next hill is so far away. Who really goes there? When you go out west, people will drive an hour for lunch, which would be halfway across our state. So I think we have a little bit of a kind of a small town, a great ethic, in that way, but it also holds us back from pulling together and saying, here's what we have in common, here's the things that we need to accomplish together. So our autonomous independence, our proclivity to that sometimes can stand in the way. So it's nice to see us trying to come together at the large level around data, almost like a highway system. We need, that we have roads, got highways. We need to maintain, that digital highway in the same way.
So, I mean, kind of brings me to that sort of public utility type of approach. And public utilities, as you know, sort of have user fees and have regulations at the state level, but have the support of both the state infrastructure, the organizations that need them to function, as well as sort of independent, fees at services. Are you envisioning that public utility as being a model for how the HIE might function or work best in our state?
I think so. I think I think you're kind of going down the right path here. They're, having user fees, because ultimately this is going to help everyone deliver better care. And as we move towards risk and total cost of care models, it's in all of our best interests to support this infrastructure. And I think, this is the way of the future. So having individual domains where each, hospital system has their own sacrosanct, information environment, we need to open this up so that we can, we can really understand what's happening to people in their care as they move between different institutions.
Yeah, as you know, Todd, that there's a lot of people that would agree to that in principle, but getting the first mover to pay the fee or open up their data is always a challenge, right?
Always a challenge. So that's, this is the cultural barrier, as I was saying. We tend to have our own kind of provincial way of looking at things. And I think even more so, both states are the same way, but in Connecticut in particular, because of our history. So can we get out of our own way to do something for the common good? That's the question.
Yeah, I think we're getting there, and I'm optimistic about that. Can you tell me a little bit, if we were to try to measure effectiveness, of an HIE or our achievement of value-based initiatives, how would we go about measuring the effectiveness of that?
I think we should use metrics around cost, quality, and meeting the goals of people. I think these are some very basic things. So if HIE is being effective, is what's the impact on those key things? Because that's what we're trying to accomplish. Those are important goals. So I think we should have a set of quality metrics that we're tracking around HIE. Is it having an impact on that? Are quality scores going up across the state? What about cost of care? Are we dampening the trend, the upward trend in healthcare costs? Are we bringing that down into a way that our employers and government can afford, individuals can afford care? And then around, are we delivering care that kind of meets the goals of people? Ultimately, we serve people, and are we again designing care in a way that makes it easy for them to access what they need, delivers the care that they want, and filters out the care that they don't want, because there is care that people would rather forego if we can make things a little simpler.
So it sounds like, really the sort of quadruple aim in essence, right? But making sure that we also incorporate the values of our patients in a very substantial way.
I'm so glad you bring that up, because, for the clinicians, the docs, the providers, we need to create a work environment where, again, it's like flying a plane. I can't fly a plane with an Excel spreadsheet. It's just not going to work. So can we create a cockpit, in a sense, for clinicians to be able to navigate the care, of these complicated patients, and for your average patient? And then also make those views available to people, to individuals, so I can see, gee, my care is on track. Here's the things I need to have done. I've gotten them done. Here's some things I do need to do, and here's some really easy ways for me to go about doing it. So HIE is key, I think, in making sure that dashboard is accurate for clinicians and for patients.
And one of the things you probably are aware of is that by state mandate, part of a legislative initiative to set up the HIE, Connecticut actually has to provide access to patients. We haven't figured out exactly what that will look like yet, but maybe it will help them actually with their dashboard of not only just knowing what care they did receive, but what care they could receive or should receive.
I think that's so important, because people are smart. I've always, when I haven't seen patients now for 5 years, but I did for over 30 years. And I always treated patients like they were medical students. These are pretty smart people, explaining things in detail, helping them understand why, I thought something needed to be done, what was the reason for that. And I think we need to kind of put in front of people the reasons why we think that you should get X, Y, or Z, procedure done, and now make it really easy for me to get that stuff done. It's easier for me to go if I know that I can get a vaccine in any of 5 different places, something that I need to have done, and keep me up to date with how my own healthcare is tracking, and am I keeping up with things in a good way. So HIE should be able to feed that view of my own healthcare to me.
Yeah, that's a wonderful observation. So, Todd, this has been an excellent conversation, and I really appreciate the time you spent with me. As you're kind of thinking about any parting words of wisdom, what would you say to our listeners?
We're engaged in the most complex human endeavor on the face of the earth, delivering healthcare to people. We're not delivering packages, it's life or death. And it's wonderful work, it's meaningful work. And going about the business of improving that care is something that I think we can all feel proud about. So, Tom, I would say to you and the folks at Connie, just keep plugging away, trying to make this informational highway work better, for the good of people.
Thank you, Todd, and thank you for spending some time with us today.
Thank you, Tom. Much appreciated.
As always, wishing you the best of health. Your host, Tom Agresta.